Okay, welcome everyone to our webinar today, Food Safety Education Using a Positive Deviance Approach. We're very glad you're with us. Just to give you a quick overview, the Partnership for Food Safety Education, which is sponsoring this webinar, develops and promotes effective education programs to reduce foodborne illness for consumers. We're a nonprofit that relies on grants and donations, and we serve people who teach consumers about food safety. So that's all of you. We call you BAC Fighters. We love you. You're public health officials, dietitians, registered nurses, sanitarians. So we're so glad you're here today for this really interesting new research you're going to hear about. Your learning objectives today: attendees will be able to design programs and interventions based on assessment and positive deviance research. Attendees will be able to list 3 factors that increase consumers' likelihood to adopt safe handling behavior. Identify at least 2 motivators for consumers to change food handling behavior, and you'll be able to describe strategies to overcome health professionals' barriers to delivering food safety education. I'm proud to introduce our speakers today: Yahua Feng, postdoctoral researcher at the University of California, Davis; Christine Bruhn, Cooperative Extension Specialist Emerita, also at UC Davis; and the moderator, Mary Saucier-Choate, Partnership for Food Safety Education Manager of Outreach and Stakeholder Engagement. So welcome to our speakers and to everyone here today. A little bit of housekeeping: 1 hour of CEU is available to attendees from CDR and from NEHA. We've made it easy for you to get these certificates. Right now, you can download the certificate right before we start the webinar, or even during the webinar. On the bar to the right of your screen, you can click on handouts, and you'll see there's 3 of 5 handouts. You can download the NEHA or the CDR certificate. You can also download a handout of the slides if you like to follow along and make notes on them. Also, you'll get the CEUs in the follow-up email you'll receive after the webinar. If you're a BAC Fighter and you're on our weekly e-card list, you'll receive it next week in the e-card. If you're not a BAC Fighter, we encourage you to go to fightback.org and sign up for free weekly e-cards full of resources for BAC Fighters. And anytime you can go to fightback.org, click on the Events tab, and the drop-down menu will show you recorded webinars, and that's where you can get all the webinars as well as the CEU certificates when they're available. So I hope you do that. At the question portion of the webinar, please use the question box again on the right of the screen to ask a question. And then after the webinar, you'll receive a brief survey, some of the questions which the presenters have asked us to send to you. So please fill this out. It helps us to improve our offerings to you. I'm going to kick it off with our first poll question, which is: please tell us what your occupation is. Let me launch that poll. So the questions are you a registered dietitian, a registered nurse, a health educator, cooperative extension staff, or nutrition or food science faculty, or a student? Wow. A lot of registered dietitians, looks like, but I'll let you see the results in a few more seconds. We usually leave the poll open for about a minute, but if you all answer, we can shut it earlier. Okay, just a few more seconds. It looks like we're pretty much answered. Okay, so now we're going to share the results of the poll. You can see that almost half are registered dietitians on the webinar today. Even number of health educators and cooperative extension staff, nutrition and food science faculty, and 9% students. Good for you, students. This is great to get a head start on understanding the research, and 2% registered nurses. Great. So I hope you'll share this recording with staff who couldn't come to the webinar today. Okay, so let's move on now. Our first presenter is Dr. Christine Bruhn, and so I'll let you begin, Dr. Bruhn.
Thank you so much, everyone, for joining us. We're delighted to share our recent research with you. First of all, let me give you some background that you are probably quite familiar with in regards to food safety. There we go. The Centers for Disease Control estimates that people do become ill. We might not think that is the case. Often foodborne illness is misdescribed as stomach flu, but in fact 1 out of 6 Americans do become sick every year. For many of us, this is just a minor, relatively minor annoyance, but for others, it can be quite serious, with estimations of 128,000 of people being so ill they end up in the hospital, and 3,000 dying of foodborne illness. This is just unacceptable. So if we're looking at ways people can help reduce their own risks, we need to know we need to look at what people do and what they know. And our research has found that people don't always comply with what they know. Several surveys have asked, oh, do you know that your chicken should be cooked to 165? And many people say yes, they know. 60% say yes, but only 5% actually use a food thermometer to check if their chicken has reached that temperature. And similarly, people know that hot foods should be held at 140 degrees Fahrenheit. If you give them a survey, they will click the right answer. However, if you follow that up with, do you use the food thermometer to make sure your food really is at that temperature, we get 0 on that one. And looking further, if you ask people, what do you do to help make sure your food is safe? Almost everybody will say, oh, I wash my hands. But when we go into a kitchen with the person's volunteered, they know this, they're being videotaped as they are preparing a meal, we see 64% did not wash their hands before meal preparation. We see 1/3 of the hand washing activities did not involve soap. And we found almost 40% who did not wash their hands after handling raw chicken and then going out and started making their salad or cutting up their fruit. Further, we find that cooking is not always adequate. People might know that their burger should reach 160 degrees, but when they declare their burger done and we stick a thermometer into it, we find 25% of the burgers have not reached that temperature. Why? Because the consumers, are not using the thermometer to verify it. And similarly, people undercook their chicken. They're looking at color, they're relying on appearance, they're cutting it open, and the chicken may look white, no longer translucent, but it could be as little as 145 degrees. So 40% of the more than 100 consumers we surveyed undercooked their chicken. Now, one of the reasons that people might act carefully is if they think they are potentially at risk. But actually, the common perception is that I am not at risk. This is called optimistic bias. You've probably heard that before. When asked, are you at risk for foodborne illness? We have almost 60% who say, oh, I am extremely low risk for foodborne illness. This barrier is significant in that people just don't think safe handling is necessary. It's not important. Our response to that is you need to do it for those you love. Practice safe handling for those you love, for your family, for your friends, for your guests. Some people are at highest risk for foodborne illness. We are all at some risk, but some at increased risk. And this includes pregnant women, children, especially those who are less than 5 years old, older adults, and older is remarkably young, certainly over 65 years of age, but in some studies as young as 50, people with diabetes and other conditions, medical conditions, including those who are immune compromised. Now, traditional education, which we have all used, relies on information sheets and posters And often it's one-way communication, either looking at the poster or I as an educator tell you, do this or do that. There is material available for specific high-risk groups, such as the pregnant women or people with immune compromised or those suffering from cancer. It has been made, but it's often not distributed to the patients. Well, previous studies have found that it is more effective if you can have a food education program that's designed and targeted specifically for those people. And if you tell them not only what to do, but why to do it, and you involve them in the discussion. So this is the exciting work that Betty Feng, my postgraduate research assistant, has been able to develop, and she's going to share that results with you now.
This is Betty. I'm going to share how we develop, evaluate, and apply positive deviance to food safety education. Positive deviance approach was first introduced into the nutrition education area, based on the observation that in every community, even if everyone is sharing the same limited resources, there are always individuals whose uncommon practices will make a difference. And we call those unique or uncommon practices as best practices. By using a positive deviance approach, we can identify those best practices and promote them within the community or group. So our study, there are several stages, but the first stage was to develop and evaluate. So we compared positive deviance with our more conventional one-way education models, including standard reading materials, which are informations that we adapted from USDA FDA's website, and stories. It's also one way, but we made it a little bit fun. We developed personal stories featuring our target audiences like pregnant women, people with diabetes, and delivering the same materials as standard reading materials. And the third one is positive deviance. So as for the target audience, we are looking at two groups, pregnant women, people with diabetes. At the time of research, both of the two groups tend to have less education materials out there featuring food safety. And to measure the effectiveness of the three educational models, we used pre and post self-report survey, and then we follow up with them after 2 months and 3 years, just to see how much retention after the interventions. The program contains 5 sections. The first 4 aligns with our fight back recommendations: clean, cook, chill, avoid cross-contamination. We added choose safe food, especially for our high-risk population. In each session, we always started with a behavior. So, for example, if we are talking about the cook section, we will start with a behavior, use thermometer. So we will ask them, how do you know when the burger is done? Participants will offer their behaviors, their cooking activities. We will identify the positive deviance who uses the thermometer, which is our recommended practice. Sometimes, if there is no positive deviance could be identified within a group, really, no one really used the thermometer. At that time, I will mention that there was a pregnant woman I know who used a food thermometer and what she did. Through the discussion, we talked about why this practice is important, is recommended. Previous research suggests that the reasons behind the behavior can make it more memorable. And then we will ask the participant to commit to trying the practice and complete the take-home tasks. We're going to talk more about take-home tasks a little bit later. Because it's a discussion model, so we not only collected quantitative self-reported survey data, we also got a lot of interesting in-depth quotes. For example, we will ask them, do you know the temperature of your refrigerator? A representative quote was, I don't know the temperature in my fridge. As long as the drink is cold, it should be good. But within the same group, we got our positive deviance who said she will use a thermometer in her refrigerator, and it should be always below 40 Fahrenheit. This would be the leader of the group. We included take-home tasks to support the messages. In the clean section, after the clean section, we asked them to observe at least 3 people's hand washing practices around them. And in cooking section, after that, we asked them to record 3 items, food items, they thought it's done, and then measure the temperature. Chill section, we asked them to record their home refrigerator temperatures, including door, top shelf, and bottom shelf. Cross-contamination section, they will record how many times they clean the kitchen items within a week. Here are some results we would like to share. So this is from the chill section. We ask the participants to go back home and measure the refrigerator temperature. 40 Fahrenheit is the recommended temperature. We can see that many participants have a higher temperature than 40 Fahrenheit in their refrigerator, especially doors. And there was even higher temperature than 48.
Oh, sorry. Oh, sorry. There we go.
And also, we measured how many times do those participants clean their kitchen items, including utensils, countertop, sink, and cutting boards. Not only us, even a lot of the participants were surprised that there were people who do not clean their countertop and sink within a week. Next one. So we not only collected data from take-home tasks, we also collected data self-reported pre- and post-survey. It suggested that positive deviance intervention has the largest knowledge change in regards of foodborne illness compared with standard and story. We did not just stop at the knowledge change. We also want to see how do people change when it comes to behavior. So we captured food thermometer use from immediate pre- and post-survey, 2-month, and 3-year follow-up. We noticed that after 2 months, positive deviance group have a pretty good retention. However, story and standard reading materials, those 2 groups have significant drop. And after 3 years, the rate of decreasing is lower. However, it's still significantly dropped. We see that after 3 years, positive deviance group have a decline. However, it still has a highest retention among all 3 interventions. So now you might have the question that why positive deviance approach could be so effective. There are several components which will make positive deviance unique. People tend to like to follow leaders from their own community. They like to mimic their leaders' behavior. And also, by discussion, understanding why they should wash their hands over 20 seconds, why they should cook their chicken over 165 Fahrenheit. All of those reasoning behind the behaviors are helpful for them to remember and then understand the importance. And also, providing them take-home tasks. This gives them another chance to practice the behavior so they know what to expect and then report their experiences. Sharing their practices can also encourage them to follow the practices. We not only captured people's knowledge change, behavior change, but also by using the discussion session, we better understand what are the barriers to following safe food handling practices. We identified 3 main factors: internal, including knowledge, cooking habits, and taste preference. One of the participants, when we talk about do not wash chicken under running water, a participant told us that if I don't wash the chicken, I don't know how to cook it. You know, it is slimy and sometimes has blood on it. That's their cooking habits. They learned from their mom, grandma. And the second factor, social cultural factor. A lot of people facing social pressure and different living conditions limited them. So one of the participants, when we talk about avoid cross-contamination, she said, well, it can be hard to avoid cross-contamination in a friend's dinner party. If I keep reminding others on following the rules, I don't think I will get invited again. The third factor, medical factor. Pregnant women often talk about they have morning sickness and there are certain food items they just want to eat. Some just want to eat sushi. And people with diabetes, they mentioned a lot about their time constraints with meal preparation. Next. Within people with diabetes and pregnant women, they had different barriers and different knowledge change pattern. We even observed, we even noticed that pregnant women had a lower turning rate of take-home tasks and less involved in the discussion group. Why are those? People with diabetes, we identify them as a more long-term, they have long-term condition. They need to focus, they actually are more motivated by the improving diet and health for the long-term condition. While pregnant women, they're facing more short-term condition, they're more focused on the childbirth. And also those two groups fell into 2 different age groups. And also they were recruited in different areas. People with diabetes, we recruited them in Sacramento, which is a metropolitan area, while pregnant women, mostly they're in Davis, which is a university community. So after the first stage of positive deviance program, we noticed that this is a promising approach. So we got further funding from our STAG CAP grant and to develop positive deviance curriculum for both high-risk population and the next generation food preparers. Next. First, next please. Yes.
Did it go? There we go. Sorry.
Thank you. Yes. First, let's talk about positive deviance curriculum for high-risk population. So now we developed the program. So what? Now what? We want to deliver these materials via trusted sources. I'm really glad that almost half of our participants are registered dietitians, because we need to talk to you. In 2012, IFIC reported that nearly 90% of the consumers consider their health professionals, including physicians, registered dietitians, registered nurses, as the most trusted source for food safety information. Next. However, our health professionals are not as confident as we expect them to be. 40% of the physicians reported they're not confident in their general knowledge about foodborne illness. There are 40% of RDs and RNs reported providing food safety education to their high-risk clients. However, less than 10% will use a structured class or video to provide the information, which was suggested to be the most effective way compared with just a one-page handout. Next. So later on, I conducted some focus groups with health professionals, and to identify the motivators and barriers to deliver food safety education. The motivators, including they want to see a more effective curriculum, they consider their patients needs more food safety education. They themselves would like to update themselves, and they like to see more materials could combine food safety and current nutrition education. We also identify some barriers. On the left boxes, those are top three barriers from qualitative focus group study. While on the right, the percentages are what we get from a 200 health professionals survey. So on the left, you can see the top barrier for them was lack of management approval. They want to deliver this, however, they may not have the support. The second is patients generally are not interested in food safety topic. And the third, they do not have enough time and resources. When we try to quantify those barriers, we noticed some difference. The top barrier for the 200 health professionals we surveyed was patients generally are not interested. 40% of them thought so. And 27% thought they do not have enough time. 37% thought they do not have enough resources. Next. I also worked with a group of health professionals within women, infant, children. From them, we identified some specific barriers to their participants, including they have unique cuisine and cooking habits, especially within the cross-cultural community. And they generally cannot afford more equipment like thermometer. They have especially low food literacies, and they would like to see more materials other than English. Next. To impact the public, Christine and I trying to seek more funding opportunities. Recently, I was funded by USDA a postdoctoral fellowship to develop and evaluate a culturally tailored food safety positive deviance curriculum, specifically for low-income minority groups. So let's talk about The other half, the curriculum for next generation food preparers. Here we focus more on high school students. From the previous studies, we noticed that the students need food safety education. A little bit over half of the students thought chicken was cooked thoroughly when the internal temperature reached 100 Fahrenheit. 62% thought as long as we wipe off by using clean paper towel, it should remove the bacteria from raw meat. And 71% committed that they often do not wash hands before eating at school cafeteria or restaurants. Next. So currently, our Positive Deviance food safety curriculum have been piloted in 3 high schools, 2 in California and 1 in Washington State. We not only collect pre and post self-report surveys, we also collected data by using a cooking lab. So we videotape how they cook hamburgers before the curriculum and after the curriculum. So the take-home message of this session is when Positive Deviance approach has been evaluated and it has a significantly higher knowledge change compared with other conventional educational models. The participants tend to be more engaged to learn and practice recommended behaviors. And some participants even invited us to their own community to deliver this material. So they indicated that they would recommend the program to their family and friends. Currently, we're trying to develop more curriculums to combine food safety and nutrition using Positive Deviance approach and evaluate the effectiveness of the curriculum delivered not by us, but by the trusted sources, health professionals. And we want to promote the importance of food safety education among our health professionals. Last, yes.
We have a poll, Dr. Feng, so let's put this out there. Dr. Feng and Bruhn suggested that we ask you what location would be most useful to post this Positive Deviance educational program. So let me run that poll for you. Okay, let me launch it. There you go. Okay, so if you would let us know what location would be best for you for getting this kind of Positive Deviance educational program. A government source such as foodsafety.gov, a nonprofit such as our Partnership for Food Safety Education, a university food safety website, or would any of these locations work as well for you? So we'll give a few more seconds to let everyone weigh in there. Okay, just a few more seconds because folks are still voting, letting us know where you'd like to see this information on the web. Okay, I guess I'm going to go ahead and close the poll and let you see what the results are. Okay, you can see that it looks like 60% say any of these locations would be fine. I guess the big thing would be letting people know where to go to get that information. 33% thought a government source would be best, and 26% would like a nonprofit source, and 6% said a food safety, university food safety website. So there you go. That's helpful information for the researchers here. And now let's continue on to wrap up the webinar. Dr. Feng?
Yes.
We're ready for the next slide.
Can you not see it, the acknowledgement?
No.
Okay, hang on. I did something wrong probably. All right, there.
Last but not least, we would like to thank our colleagues from UC Davis, Women, Infant, Children, UC Davis School of Medicine, and Sutter Health Foundation. We want to especially thank our funding source, USDA NIFA. Thank you for attending this webinar. And if you're interested in our positive deviance approach, or if you like to pilot using our curriculum, please contact us. This is our email address.
Okay, and this will be, of course, on the slide handouts, which you can get from the Fightback website. You can also contact info@Fightback if you can't find that. Now it's very exciting because there's plenty of time for questions. People have been asking them the whole time, so that's great. Now let me just open this up so I can start with the questions that have been asked, and please continue to ask questions with the question box in the corner there. Okay, so I'm just going to scroll up. Okay, okay, so this was one question. What percentage of participants were retained over the 3-year study? Dr. Feng.
Yes, this is a very good question. So in the 3-year retention, that part, I only collected data from pregnant women. And the retention after 3 years for the positive deviance is a little bit higher, which is about 50%. While for the 2 other, story and standard, are especially low. So for story, it's about 25%, and for the standard, it's about 20%. So as I mentioned, that the pregnant women group we recruited in Davis, and it's a university community, so there is a very high mortality rate we expect actually over 3 years. And also they changed they either relocate after 3 years or they changed their contact information. So we tried our best to try to track down who participated and who answered. So originally, when we designed the program, we did not really expect we could be funded until we can collect the 3-year response. But in the future, if we have like a longer source, like longer time of funding source, we would love to design it in the first place so we can like better recruit people to expect they will last longer in this study. This is a good question. Thank you.
Yes, that was so powerful, that 3-year study results, that people still retained that information. Okay, another question. Is there a recommended length of time for the homework and follow-up? For example, when you give the homework, when should you follow up regarding behaviors? How long of a time between give the homework, get the results from the folks?
Yes, the homework follow-up is about a week. So we meet every week. It's a 3-week program. So the first week we delivered cook and chill. The second week we delivered clean and cross-contamination. So after we deliver the information, they will go back with their take-home task. So we will meet every week. So a week will be how long they can complete their take-home task.
This is what worked for us, but the program's flexible. So if someone is incorporating this into their activities, you know, they can judge the interval, whatever is appropriate. I think a week is minimum. You've got to give them a chance to cook a bunch of different foods and easily fit in this little extra activity. It's not set in stone.
Great. Here's another good question. Where can they find your research? Is your research published in journals, or is it not published yet?
So currently, the first part of the study has been published with the pregnant women and people with diabetes. So we published one paper in food control, which is in 2016, and another paper was in Journal of Food Protection Trends, also 2016. No, it's British Food Journal, 2016. And we are currently working on the other half. We're going to publish earlier next year.
Yeah, we're working on the manuscripts for the high school things right now. And when you get the slides, you look at the slides. If our paper is in there, it's the notation is at the bottom of the slide.
Right. Thank you. That's right. You can look at the slide and look at the citation at the bottom for the things that you've published. Great. So how many people were you able to follow for 3 years? You mentioned that you did try to follow them. How many did you actually get over that 3-year period at the end of 3 years?
In total, there are about 30 in total.
Okay.
Yeah.
Now, another question. With the take-home tasks, did you also encourage the learners to involve their partners and or age-appropriate children? Or did you say you're the only one who can do this, the actual person in your class?
We think it would be great to involve partners or children. We just gave them the task and had them do it. The primary function of that task is for them to see that it's easy. You know, taking the temperature of something is not hard. We want to overcome that barrier of difficulty. And as far as hand washing, that's pretty much what they observed. They could easily include their children in the what's the temperature of your refrigerator thermometer, because we did give them refrigerator thermometers and cooking thermometers so that they could place these inside, for example, the refrigerator thermometer in the different locations inside the refrigerator. We mentioned that they should be in there for a few minutes to equilibrate, you know, at least 5 minutes, just an arbitrary time. But certainly you can involve the kids in, okay, what does it read? You know, depending on how old the child is and how well they're able to do that. So we didn't specify to be sure to do this, but if you're teaching a family-related class, one could adjust the take-home tasks so that it includes all members of the household.
That's a great idea. Good question. Now, another question from our participant is, and you sort of already mentioned this, but when do you expect to have the high school curriculum ready to share with the public? I know, is this the one you haven't published yet, the study? Is that correct?
Yes. Yes.
So first you have to publish it. Okay.
Yes. Currently, we had 3 high school teachers worked with us. We definitely welcome more high school teachers who want to work with us on and to optimize this curriculum before we share this with the public. And also, currently when we recruit high school teachers to work with us, we have some challenges too, because some of the high school teachers would like to see this also meets certain next generation science teaching standard, things like that. So we definitely would like to work with more high schools and high school teachers to make this fit the high school current curriculum better.
Yeah, so we'd be actually especially interested if any of the people in the listening audience there would like to collaborate with us to try this in their school a little bit more and give us feedback. We feel every time we send it out for pilot, we get some really good suggestions for people. So we would be delighted to work with someone. Recently, one of the schools that was delivering this information delivered it to a school that was training their kids in food service. So the young people had, some of them already had a food handler certificate or a safe food handling certificate. And my, oh my, judging on the observation as they prepared a meal, a specified meal, the information had not stuck at all. It was, they might have heard it, but they were not practicing it. After exposure to the Positive Deviance curriculum, however, that Follow the Leader curriculum, we saw significant improvement in knowledge and in behaviors, but also pointed out some areas that we needed to give a little bit more attention to guide the teacher in directing the students on how to follow the practices carefully. So I think with the high school, we would love to have a collaborator or two to help us try out the program. And then after we fine-tuned it a little bit more, we're ready to share.
Great. Now, another interesting question. Can you please tell us, how did you identify positive deviance in high schoolers? Was it the same way as with the adults, or did you do something different?
Yes. So working with high school students is a little bit different. So with the adults, we work with them like in small groups. Small groups, we say 6 to 10 people. But with high school students, we're often facing a larger group, at least 20 to 25 students within one session. So what we do similar, just to ask them to share. But a lot of the times, the high school students, they do not really do the cooking in their own home. So they will share what they learned from their parents. Based on my current study with like a low-income minority group, the observation study, we noticed that most of the participants actually learn how to cook, not from school, from their family, from their mom, from their grandma. So that's why we are more confident, more comfortable working with high schoolers as long as they share what they learned, what they saw from their family, how they cooked. And then we identify positive deviance based on what they shared from their family. So it's a little bit different from adults who actually do the cooking. High schoolers, they will share, they will get the information more from where they live, how their parents do or grandparents do. So that's the difference. But other than that, mostly the sessions are the same. And another thing is we also included some fun little activities in the high school curriculum. So the high schoolers can have fun working on them. So, but however, some classes have more time to play around with the activities. Some classes have the time constraints, so could not. All of those could be optional. So that's another beauty of this this curriculum. You can add more to it if you have more time. If not, you can cut something. Yeah.
Great. What great questions. Well, this is good to know that if there are high school teachers or other folks listening who want to get on the cutting edge of this and help you to refine this process, these methods, they can contact you and get curriculum. Is that correct?
Correct.
Yeah. Okay, so we're running out of time for questions. Again, Dr. Feng and Dr. Bruhn's email address is right on the slides that are posted here. You can also get them from the Fightback website or from us. So we have to end the questions section now. And I just have to give you some information that you probably already know if you're BAC Fighters, but if not, you can always hear about upcoming events in your e-cards. July 25th, we have a knowledge exchange, which is a teleconference, audio only. Clostridium perfringens, anatomy of an outbreak. In August, we're going to kick off September's National Family Meals Month with the Food Marketing Institute, with a brown bag webinar promoting food safety and family meals, your best resources. So this is National Family Meals Month is something Food Marketing Institute does every September, and we're going to jump in with them to promote food safety, including a number of things, but my favorite thing, recipes that include food safety steps built right in. So that's something you can look forward to. If you're not following us on social media, please start. Particularly Twitter and Facebook, and also LinkedIn. We're there, and we post every day, so you can steal our posts, share and retweet to consumers. You can share great information. Right, if you're not getting our weekly emails, you're really missing out. So fightback.org, you can sign up there. I love spreading the word, sharing information about backfighters and what you're doing out in the community. It's great to share ideas, so please contact me, mary.choate@fightback.org, and let me know what you're doing, because we love to learn from each other. If you haven't been to fightback.org, or if you haven't been lately, or if you've never been, I so encourage you to go. Look at all these programs. Ready to go consumer information you can download, print out, bring to classes, bring to health fairs, repost, share on social media. So you can see all the things here, too much to go into, but everything from meat to poultry to produce and more. I also want to mention one thing that isn't on here is our evaluation toolkit, which can help you if you're not doing evaluation, whether you're just starting or whether you want to refine what you're doing. Our evaluation toolkit, which is also found at fightback.org, is a really great toolkit leading you through with lots of handouts, lots of information to help you evaluate your programs. And we just want to thank our partners. We couldn't do this without our sponsoring partners. So we thank the sponsoring partners you see here: Cargill Produce Marketing Association, Food Marketing Institute Foundation, Grocery Manufacturers Association, and NSF.org. And also we really thank additional thanks go to Community Connectors: Walmart, Ecolab, PMA, FMI Foundation, Sealed Air, Cargill, Foundation for Meat and Poultry Research, General Mills, the Hershey Company, NSF International, USDA, FSIS, 3M, American Frozen Food Institute, International Association for Food Protection, and Land O'Lakes. It only happens when everyone pitches in. So we thank everyone. And I guess that's it. Thank you so much for joining us today, and hopefully we'll see you at the next Knowledge Exchange in July, or before that at fightback.org. Thank you so much for joining us today.